Rebecca, welcome. Thank you again for all the support in maternal mental health. And I'm going to turn it over to you to introduce your panel.
Perfect. Thank you, Joy. I hope everyone can hear me. I will admit that somehow I have avoided moderating a panel over a virtual conference in the last year. I'm sure others have done it loads of times, but we're going to hope that this goes smoothly. So as Joy said, my name is Rebecca Alderfer. I work with the ZOMA Foundation, which is a private foundation based in Denver, Colorado. And part of the work that ZOMA is engaged in is making sure that a woman's mental health is prioritized and attended to throughout pregnancy in that first year postpartum, and that there are appropriately trained professionals able to support and care for women across the continuum of perinatal mood and anxiety disorders. Most of our work is based in Colorado and focuses on the state of Colorado, but we also work nationally to help support efforts that will raise all of our efforts in this area. And so it's just a pleasure to be back with you all again. I want to give just a quick shout out to all the stakeholders from Colorado that are participating and listening. We have such a wonderful active community and are doing wonderful things across the state. It's great to have you all with us. So I told Joy that I was going to kick off this panel with just a couple of slides that I think Sarah's going to put up for you all that are completely unconventional. Our panel today is around advancing improvements in care. Are folks able to see the slides? Sarah, does that? No, I'm not seeing them. Perfect. Well, we'll just keep on going. So one of the things that I was thinking about with this panel, advancing improvements in care and bringing all of these different perspectives together is what have we seen in perinatal mental health over the last several years? Oh, here we go. We've got them. Next slide, please. So the unconventional piece of this is I'm going to use a traffic analogy. As I've watched the conversations over the years, it's really felt a little bit like a four-way stop, where you have all these cars and all these actors coming to an intersection, and we're there, we're all motivated to move forward. We have places to go. You can keep advancing the animation on the slide. But we're waiting for sort of a set of cues. Who's going to go first? We all have to act in concert in order for this to be a safe outcome for everybody. A lot of times we have had providers wanting more care options before they go first. You have care options wanting reimbursement before they're ready to move forward. You have payers wanting to make sure that we're focused on return on investment and really have some cost drivers that we're paying attention to. And then you have companies who are inundated with options for new services and platforms, and we're all stopped, kind of waiting for those subtle cues. And I think, as Joy referred to in that opening session, we really are at a tipping point, thanks to the work of advocates, providers, policymakers, funders, industry, and more, where this four-way stop is looking more and more like a roundabout. Next slide, please. We still have rules of the road. We still have cues that we're looking for, but instead of coming to a stop, we're really just yielding. We're making sure that mothers and families and babies are at the center of the work that we're doing. And we're figuring out how we move to the next place more efficiently. And the panel that we have today are navigating all of that. They have interesting solutions. They have bright spots. They have things that they've worked out to help us move even more efficiently than we are today. And the beautiful thing about a roundabout is that you can go around the circle as many times as you want, testing, innovating, figuring out how we're going to make this care for mothers, families, and babies even better. And then you can get off and move ahead to that next place that you want to go. I think there's a lot of opportunities here. We're going to ask our panel, next slide, to really talk about how you hold mothers, families, and babies at the center of this flow. They're going to unpack some sector considerations and trends for us. What are we talking about when we talk about collaborative care, when we talk about return on investment, when we talk about value-based contracts, or even prescriptions for mental health? We're going to share some wins, and then we're even going to talk about scripting some actions for implementation. So what are some really tangible and doable things that all of us can then talk about and figure out how to implement after this panel? I'm really excited to be with them. I'm excited for them to introduce themselves. And so I'm going to turn it over to each of them to sort of say a little bit about who they are, the organizations that they work for, and the work that they're doing. And then we'll get into some real questions in the meat of the conversation. So I'd like to start with Dr. Laura Clapper. Laura.
Laura, please unmute and turn your camera on.
Okay, great. Thank you. Can you hear me, Rebecca?
I can.
Okay, perfect. I had a little trouble. It wouldn't let me unmute myself. So I'm Dr. Laura Clapper. I'm the Chief Medical Officer for Cigna for Southern California and Nevada. I'm also a board certified pediatrician. And the Cigna is a global health services company, and more than 10 years ago, Cigna really took the position that it was more than an insurance company. It was really thinking about how do we hold our customers at the center and really offer services. So that was a transition we've been through. And in the last 2 years, particularly, we've been focused on how do we increase the mind-body focus and really support be holistic in how we support the total person. My personal experience has been that I've been involved in behavioral health integration in general, not just perinatal mood disorders, for more than 30 years, starting with my time as a Navy physician. It's very important in the military to think about the whole mind-body connection, and really connecting through both in clinics and provider groups, as well as my experience in several health plans, on how do we bring forth this integrated, connected support of the customer. I think what's really struck me in the last 2 years, and I think it's particularly important as we think about perinatal and supporting the mother, family, and babies, is that we think about behavioral health integration as kind of a general focus. And I have to say, this is a big aha for me. And we really need to think very specifically about perinatal support and perinatal integration, because other than that, people are very focused on how we're going to go to work with primary care and how they're going to refer to general behavioral health. Well, that really doesn't address a mom's need who's being cared for by her OBGYN care team. And then how does an OBGYN refer to a specialist in perinatal mood disorders and support moms? It needs to be specialized. And sometimes when I'm talking to internally, as both as when I'm talking to medical groups, I really talk like we would not send somebody with diabetes just to general primary care referral. We would send them to an endocrinologist. And we need to have the same thought when we think about referring a pregnant mom or a postpartum mom to behavioral health, that she needs to go to a care team that specializes in perinatal mood disorders. So that's really, I think, a change in my thinking, because not only will it have increased identification, but also making sure that when someone is referred, that they get to the right place the first time. And, as we think about trying to get people who are identified to the right treatment in the shortest amount of time, is access, but it's also getting someone to the right provider who knows how to take care of folks, with this condition, because otherwise families and moms are going multiple places and they get discouraged and they don't get the treatment they need. So I think that's one of my big ahas and when I think about this.
Perfect. Thanks, Laura. We're going to keep introductions brief, and then we'll get into the meat of some of these topics. Barry Green, I want to turn it over to you.
Yeah, thanks, Rebecca. And hello, everybody. Thanks for having me. I'm Barry Green, the CEO of SAGE. And what we've been focused on for the last decade is deeply understanding brain circuitry and then developing very specific medicines that allow us to change that brain circuitry in ways that modify brain health. And as SAGE, we're leaders in brain health. That program approach that I've described actually has worked. SAGE was the first company to get a drug approved for postpartum depression that's available to help moms today. So I'm thrilled to be on the panel and happy to dive in more as we continue.
Wonderful. Thank you, Barry, so much. We're going to turn to Nekia. I even practiced, and I think I got it wrong. Nekia Lewis from Verizon. Nakia, I did it. Oh, we can't hear you, Nakia. Please unmute.
So sorry, you corrected yourself with me on mute, so that's perfect. Hello everyone, Nakia Lewis from Verizon Communications, and I have responsibility for a health and wellness strategy across our domestic footprint. Verizon Communications, of course, our mission, vision is to deliver the promise of the digital world to our customers, and my customers happen to be our employees and in human resources as a human resources professional. In this capacity, I have responsibility for our total wellness strategy, working with population health management strategies across our carriers, our health promotion and communications campaigns to employees, on-site events, and a number of other collaborative initiatives with other entities within human resources. In this capacity, I also have responsibility for our maternity services across all of our domestic programs. Professionally, I've been at Verizon for about 5 years. Before that, I spent about 10 years at a single state health plan and worked at a nonprofit organization focused on disparities in maternal child health. So I am really excited to take all of those experiences and bring them to a large employer such as Verizon, who has a commitment that we have to expectant families and to working with our carriers, with consultants, with large organizations to advance policy and plan design to support working families.
Wonderful. Thank you so much for being with us. We're going to turn now to Dr. Emily Miller. Dr. Miller.
Hi, thank you so much. I'm Emily Miller. I go by pronouns she and her. And Rebecca, thanks so much for moderating. And I'm just honored to be with this esteemed group of panelists. It's been a lot of fun so far. I'm a maternal fetal medicine physician, which means I'm an OBGYN that did some subspecialty training in high-risk obstetrics. So I take care of pregnant people who have complications during their pregnancy, whether that's complications for the pregnant person themselves, like pregnant people living with HIV or affected by diabetes, or pregnant people with fetal complications or conditions. From a perinatal mental health lens, I am the program director and founder of Compass, which is a collaborative care model for perinatal depression support services that's at Northwestern University in Chicago. It's adapting the collaborative care model, which is a well-established health services intervention, to optimize delivery of mental health care in the primary care context and adapting it to the perinatal context, because it's certainly very different on the provider, patient, and system levels. It's been a program that's been around for 4 years. We've been the very grateful recipients of the 2020 Mom Innovation Award in the past. And it's, I can tell you, a program that has really changed the culture here in terms of our obstetric clinician comfort with perinatal mental health identification and treatment. Excited.
Wonderful. Can't wait to hear more about that as we talk about what advances in care look like. And lastly, I want to turn it over to Dr. Jennifer Moore. Dr. Moore.
Hi, everyone. Thank you for the invitation. I'm really excited to serve on this panel. I'm Jennifer Moore, the founding executive director at the Institute for Medicaid Education. IMI is a 501c3 nonprofit, nonpartisan research and policy organization. We lead a wide range of topics and projects specific to Medicaid, everything from large data analyses to national learning collaboratives. As it relates to our perinatal and mental health work, we embed all of our mental health work within the maternal health portfolio, which is very expansive, ranging from work around midwifery-led models of care and birth equity to doulas and perinatal community health workers, and thinking about those topics within the concept of maternal mental health. So really excited to be here today and to participate in this panel.
Wonderful. Thank you all so much. I'm going to start off. I already sort of gave my vision of, just the field in general, the ecosystem around maternal mental health, moving from a place where we're sort of waiting for each other, where we're hesitant, to a place where we're really fluidly evolving together, and centering around mom and baby. I'd like to turn to each of you because you all sit in a different perspective around perinatal mental health, and yet we're all in this together, to talk about if we hold mom and baby and families more concretely through that at least 21-month period of perinatal experience, sometimes longer, what does success look like from where you sit? And I'm just going to call out in different orders. So let's start with Barry. What is holding that perinatal period differently look like from your viewpoint?
Yeah, Rebecca, well, first and foremost, success is obviously a healthy baby and a healthy mom, period. But that doesn't always happen. So imagine a world where the mental health and well-being of the mom is discussed early, as often as her physical health. We certainly discuss potential pregnancy issues like preeclampsia, for example, but we don't necessarily talk about depression and the risks of pregnancy on depression. It's important that we have forums where moms can be open and honest about their mental health without fear of judgment or other fear. We need to destigmatize this and make sure that moms understand that there's biological changes happening in brain circuitry that's leading to this. It's not her fault. So clearly, childbirth is a single moment in a mother's journey. Focusing on that moment, but that's not enough. Moms need a support system before, during, and after. So we're working at SAGE to make sure that as a society, we develop better resources that ensure that moms and families in this country never need to be concerned about access to care and coverage for as long as they require it. I'm sure we'll talk more, but I've said very simply, every mom needs a plan. They need a plan for having their baby, but they also need a plan for after they have their baby in case any of these health issues arise, like depression.
Great. Dr. Moore, what does success look like for you as we advance care?
Yeah, from my perspective, and it touches a little bit on some of the topics Barry brought up, success is a system that removes bias, stigma, discrimination, and racism, that focuses on healthy mental health, where the dyad does not experience barriers in access and coverage to an integrated behavioral and physical health environment. To me, that is success.
Nakia, as you think about a very large employer, I forget the number of employees that are under your health and wellness plan. It's in the hundreds of thousands. What is holding that perinatal period and successfully holding it look like for you?
So success for us, well, first of all, we want all families to feel supported in their decision to expand their families while they're in the workplace. And success, as Barry mentioned, is a healthy mom, healthy baby that's thriving, a mom who is her best self through the postpartum period and understands that the opportunity to return to work is safe, doable, that she has options of extending her time if she needs to, that if she needs additional support, that we can help to make those linkages. And most importantly, that we are supporting families across our continuum, from the person in the call center, the retail space, the low-wage earner, to the person who is in the corporate office.
Wonderful. I love the word options. Options fits through so many of our frames with insurance, with providers, with treatment. There's always room for more options. Dr. Miller.
Yeah, thank you. I've loved hearing these answers from all of these different and so important lenses. So I think I'll answer from the perspective of an obstetric clinician. And I think my vision is, or where we need to get is have all obstetric clinicians, not just a few, but all obstetric clinicians feel confident and comfortable identifying, treating, and monitoring perinatal depression and anxiety. I also think, to piggyback on what Dr. Moore said, having all obstetric clinicians have the cultural competency to care for pregnant and postpartum people through an equity lens and to promote equity free of bias. And I think to achieve that, it's so important that it's not merely a, hey, here's another task to add to a busy plate, but rather restructuring our healthcare delivery system to facilitate the change, including things like on-site support that's often available in the collaborative care model, but there's a lot of different approaches to this. Having psychotherapy that we know is acceptable and accessible to our patients. And so really making sure that it's a, obstetricians and obstetric clinicians are given the tools in the toolbox to be able to affect this type of change.
Great. And Dr. Clapper, from the perspective of someone who's charged with covering women during this period and helping to pay for care, what does success look like from where you sit?
I see success as the woman and the whole family, so the partner feeling supported throughout the pregnancy, through the delivery, and through the postpartum period. And, I think really having a sense of well-being. So having all the care connected. And, I agree that we're really putting a lot of focus at Cigna in terms of reducing bias, looking at equity, and trying to increase access.
Wonderful. Great. Dr. Miller, you touched on this. And so we're going to go deeper around, you have a particular program that you're working on that's really about integrated behavioral health and thinking about sort of a perinatal medical home. And I think one of the things that we keep learning is that a lot of women see their obstetrician or gynecologist as their primary care physician. And yet we're not really set up that way. So talk about your vision of sort of a perinatal medical home and kind of what integrated behavioral health looks like in that situation.
Yeah, thanks. I think, integrated care has such a long-standing, strong evidence-based history to support its use in the primary care context. And obstetric practice prenatal care is like, it's kind of primary care, but it's kind of not. And I think key differences are, obstetric clinicians don't have the same training. Historically, we're not trained in perinatal mental health in any robust way. If you look at the core competencies we train our residents in, it's really starkly limited, and there's a lot of work to change that. So that's kind of from the clinician standpoint, the system is set up very differently. We see patients in the office in 15-minute increments. And we're covering a lot of ground. We're doing physical exam, assessing the fetal health, assessing maternal blood pressure, weight gain. There's a lot to cover in those visits. And so it's really hard to fit in comprehensive, both preemptive counseling as well as identification or treatment counseling during those visits. And then, I think from a patient standpoint, we have this robust, quick turnover where folks are coming from either having no clinician, which is the majority of folks that I see. Maybe they have a primary care or subspecialist, then they transition to OB. Then the most common person they're seeing is the pediatrician. And so these rapid turnovers really lead to the cycle of not having a central hub that people can recognize as this is who I need to go to. And so I think, the collaborative care model and Compass program that I work in is a great way to create a culture where mental health and a medical home for obstetric patients can continue throughout the pregnancy until 12 months postpartum. But again, it requires kind of reimagining the whole health system to be able to be effective.
I love a couple of things that you brought up and could go into them a lot more, but I know we have lots of topics to cover. I think one of the things we may want to come back to is if those are not core competencies that are being taught today, how do we change that? And I think the other is kind of how you establish accountability for the whole perinatal period, because there are so many transitions in care throughout that time period. Turning to Dr. Moore, you've been in the federal government. You run this wonderful nonprofit called the Institute for Medicaid Innovation. Medicaid is the payer for a huge proportion, majority of births in the United States. What are some of the 2 to 3 kind of aha moments or things advancing that you think are really making a difference in perinatal mental health that we should really highlight?
That's a great question. And oh, I'm getting a pop-up that says my bandwidth is. I'm going to turn off my video so I can answer your question, and then I'll work on my internet issue.
We can hear you okay.
Okay,
So.
great. I'm glad you can hear me. So you're right. Medicaid is the largest payer for maternal health. It has this social and ethical responsibility to pregnant and postpartum individuals and their neonates. And there's certainly an urgent need for policymakers to prioritize this population. And as I think about those aha moments, you know, investing in maternal health directly impacts the health and well-being of children and families, communities, and economic stability and productivity. So society as a whole really benefits when we prioritize health. However, there's not a silver bullet to achieving a healthy community. But as we start, you know, we need to critically evaluate the current maternal health system and recognize that it's not optimized to achieve the best health outcomes. We need a maternal health system that places pregnant and postpartum individuals at the center, as we have noted earlier. We need a system that aligns with high-value, evidence-based models with options and choices that encompass midwives and doulas and perinatal community health workers, creating this comprehensive and total health system for maternal health. You know, we also need a system where every clinician is trained in behavioral health and understands the roles of stigma, bias, and racism in their practice. And then finally, as I think about aha moments to transform a maternal health system as a whole, we really need to address workforce issues, and we need to ensure that the maternal health workforce reflects the community that they serve. So for me, the big aha is we need a transformation of the overall maternal mental health and maternal health system, but then looking at those different system points where we can leverage change is really critical.
Thank you so much, Dr. Moore. And that feeds really nicely into the question that I have for Nakia, which is about, you know, options, right? And how you really support women through this period and thinking about workforce, not only, you know, a workforce that is working for an employer, but the people that are surrounding them. And I know you've done a lot of work with helping your employees find community in pregnancy and early parenting. Can you talk a little bit about some of that? Oh, you're on mute.
Sorry, I try not to have background noise. So in terms of helping our employees to find community, you know, just an extension of our maternity services, we also support families who, you know, have fertility needs, surrogacy, adoption, same-sex couples, employees through our ERGs who feel connection with other women who look like them, who may have their similar experiences. And so we make sure that we support all of our families, no matter what their composition is across our employee base. We also have an Expecting a Baby page where on our intranet where all of our families can go and find resources. And a program that we have that I brought with me to Verizon was something I was doing, boots on the ground at a health plan, but I took it scalable, which is I used to do community baby showers at a health plan and wanted to bring this to Verizon. And so we do virtual Expecting a Baby events. And so we get families together and do digital virtual events using Adobe Connect so that people can build community, can chat, speak with the doctor, play games, get prizes. connect with each other afterwards. There have been spinoffs from these programs. We've had as many dads attend the events as moms, and requests for additional programs specializing in, in one topic or another. So it's a lot of fun. And if you go to LinkedIn, you will see Verizon babies in their onesies from our Healthy Pregnancy Program. We give moms a onesie at their 28-week visit.
Thank you so much, Nakia. It sounds like a great way to build community. And I'm curious a little bit about partners, and what you found with the partners at Verizon in these conversations. We talk so much about moms, and we talk a little bit less about partners, but would love to hear kind of what your reactions have been kind of across all of your different employees, both those that are pregnant and postpartum and those that are in a supporting role.
So, we don't have shy employees. So if we are leaving something out, we were told that we focused a lot on mom, but not on dad, that we needed to do more to support same-sex couples and to offer supportive environments. And so we have gone back to the drawing board and done some of those things. So we have safe spaces for employees through a dedicated mailbox to ask us questions, to challenge us, to help us to get it right. Maybe there's a spouse that's working at a different organization that says, hey, my spouse has this, why don't we have that? So we're always looking to expand services and support people based on new information that comes to us.
That's fantastic. Thank you. And Barry, I think it centers well with some of the discussions that you've had around having a plan. That we talk a lot about a birthing plan, how you're hoping the birth might go, but really talking about what is your plan when you're having concerns about mental health or other complications that may come along the way. You sit at a really unique situation where you're looking at how do you develop new treatments. And so would love to hear your thoughts about kind of what does that plan look like, and what do you think that we should see employers and insurers and providers doing to help really prepare people for what's coming?
Yeah, Rebecca, that's important. And just to comment, I love the idea of a medical home and agree that society as a whole benefits by focusing on brain health. I mean, if we can get moms better, faster, and keep them better, the mom, the baby, and society benefits as a whole. And as you said, one of the important ways of getting there is ensuring that moms have a postpartum plan, that their care teams, their employers understand that plan. And Nikia, I'd love it, those baby showers, maybe it's not appropriate, to make sure that, hey, here's what a postpartum plan looks like. Here are the things you look at, because it should not only be up to the mom to understand if they've reached a state of depression 2, 4, 6 weeks, 6 months after they have a baby. They really need the whole care team around them, their friends, their significant others, to try to recognize signs and symptoms. Because, you can all imagine having a baby at home is traumatic enough. Having a baby at home where the mom's in a state of depression, it's complicated to know what to do unless you've had that plan. So the plan should talk about what risk factors exist. The plan should talk about where to go, what doctor you're going to see. If there's an integrated facility, that's great. If there's not, who do I go back to make sure I can get that taken care of? Because the wrong time to take action is in that home with the baby, with the mom that's in a state of depression. That's the wrong time to start putting a plan together. So that plan needs to be proactive with resources and information that talk about short and long-term benefits. And as I've heard Joyce say before, it takes a village. It takes all of those surrounding the mom to make sure they know the plan and can execute that plan if that mom reaches a depressive state.
That's great. And I'm definitely going to open it up to the other panelists to see if they have any comments on that. Dr. Miller, I know when you think about a perinatal home, how would a plan work in that? And have you seen anybody doing that kind of work?
Yeah, I mean, we do it in Compass, and I think the reason we're able to do it is we have built-in support. So collaborative care by definition has a care manager or a care coordinator that's typically an LCSW that serves as kind of the central hub of the system. And so I think having that additional support and that resource who can help triage access for psychotherapy, which of course would be first line for most individuals. We also have access to really fantastic therapists and psychiatrists. So I'm in a really spoiled environment where we have people close and we can get people in very quickly and can always make sure we can get folks in that have urgent mental health needs within 2 weeks. So it takes, again, I think curating a system and being attentive to the constant ebb and flow, actually just ebb of patient needs and demands, and making sure that we're continuing to be responsive to that. But again, I think it's really about a huge overhaul that needs to happen.
Yeah, and if I could add, from the Medicaid population perspective, I practice clinically in addition to my day job at an FQHC, and we have really stepped back and evaluated how do we provide that home, and how do we ensure that all the wraparound services are included. And so we have actually brought on several behavioral health clinicians to offer that aspect, and it's within the FQHC. So we have a birth center, we have a family practice, we have a pediatric element to our FQHC, and behavioral health, and a dental clinic. And we also offer assistance with social needs. So we've got doulas, we got community health workers, we have housing assistance, we have food security department that helps folks get interlinked and connected to those pieces. So it takes a village, even beyond that medical home, and thinking about the social needs in addition to the medical needs, and then the behavioral health needs, all wrapped around. And I think in many instances that's missing for the Medicaid population, and it's such a critical element to ensure that there's access and coverage to all of those pieces.
Absolutely. And for those of you that are not familiar, an FQHC is a federally
I was just going to jump in and.
Yeah, go ahead. Is a federally qualified health center. And it's a health center that's help funded by the federal government. So just so we don't have any acronyms confusing people. Laura, please go ahead.
Yes, I was just going to add that one of the things at Cigna, where we're focused on our ACOs around our primary care focus, that one of the things that we've done to try to work on, because I think Dr. Miller has a great program, is really working on how do those primary care work with the maternity service line, or with the maternal fetal medicine folks and OBGYN, and the nursing teams that are so important that work with the specialists in terms of identification and referring both to therapy and to additional pharmaceutical treatment if needed, and how they can all work together. So we've actually worked as a convener to bring together those different groups, because I think that we want to make it so it's the access and the referral times are short. And we're actually been working on being able to have perinatal same day and next day appointments, and really trying to increase access, because that seems to be one of the big risk times from identification to actually getting into treatment. That what do you do in the meantime? I mean, what do you do if you're the physician who's done the identification while you're waiting for someone? A lot of times you're not the person actually trying to get the appointment, the patient's left. So how do we take that burden, help facilitate that, and how do we reduce the time so someone can get into treatment? Because it's a scary time for the families too, right? They have this person, and now they're trying to call everywhere and try to find out where they can get an appointment. So I think that's a really risky time. So I think that's important. The other thing I was going to say was we've also tied our social determinants of health screening to behavioral health, so we can identify and also refer to community program support, to working on helping refer and get community resources around social determinants of health.
Yeah, can I jump back in a minute, Laura? That's music to my ears, because as we interview lots of moms that suffered from postpartum depression, even moms, whether it's Medicaid moms or even moms with commercial plans, they understand that there are a whole bunch of services surround them. They actually don't know how to access those services. So they don't really know what to do as step one or step two to access. So if you're providing that, that will go a long way in this plan we're talking about. Here's the first person you call. Here's what you do. I don't want to oversimplify it because it's very complicated, but knowing what to do if you're in a certain state is critically important. And it sounds like you guys are doing that, which is wonderful.
Yeah, and I was wondering, Laura, if you could talk just a little bit more from Cigna's perspective and from a payer's perspective. How do you pay for a continuum of care, of integrated care for perinatal mood and anxiety disorders? And what are maybe one of the major advances that you're seeing in that area?
Yeah, so that's interesting. Because of parity, we need to, their medical and behavioral health, at least in terms of services, are paid the same. We do find that, and this is that we're actually I guess we actually offer, if behavioral health is with a medical group and they want to be on the medical side, we actually contract with behavioral health providers to be on the medical side. So to try to take some of the barrier out around that. I think this is more like a comment because I know that there's been concern about how people are paid differently. And I think that may be in different pockets where you have the medical side of the house has been more organized and more contracting versus, historically behavioral health has been more individual practices than contracting. So you see, I think that may be some of the differences, because as you see larger groups, they tend to be more consistent with the medical with payment. So it's not so much like it's set in stone that it's different. I think it's based on, and the other thing is, as you start to have more demand and it's harder to get behavioral health specialties, I think that, or specialists, you're going to start to see that income start to equalize, right? As people, it's hard to get in to see a behavioral health specialist, and the networks are having to contract at higher rates.
And one of the things that I'm noticing in the field, and maybe I think another panel is going to talk about this, is the expanding network of perinatal mental health providers. That it's not just highly trained, necessarily licensed clinical social workers or higher trained professionals, but also looking at peers and doulas and midwives and lots of roles, lots of opportunities for people to play a part in this. Speaking of that, Dr. Miller, just coming back to you, collaborative care, demystify that term for us a little bit. What do we mean by collaborative care, and how does it work in the perinatal period?
Sure, yeah, totally. It's, when I think, and I'm an obstetrician, so I distill things into very practical and pragmatic terms. But I think about the core tenets of collaborative care, and I think they're really threefold. The first is a care manager. And so, like I said, that's kind of the hub of the system, typically a licensed clinical social worker that's going to be the interface with patients, who's going to facilitate the ongoing monitoring of patients once they're referred to the system, kind of get them launched on their mental health care plan. The second tenet is that every patient who's referred to the system is entered into a patient registry. And so while this seems so simple on the surface, it's, I think, really impactful, where every single person who has a mental health need is entered into a system where their symptoms are longitudinally monitored. And so this allows us to be able to track who's doing better with their initial treatment plan and who's not. And so that brings the third point, which is we have multidisciplinary care meetings every week where the care manager is supervised. In our case, it's typically supervised by a psychiatrist. We have supervision by a perinatal psychiatrist, as well as me, a maternal fetal medicine physician, to kind of think through some of the nuances of the pregnancy care that might be impacting the change that we're observing. And so that supervision gives the care manager feedback on patients who aren't doing as well as we had hoped, how to do stepped care, how to adapt that care, change that care, escalate that care until we reach the goal, which is remission of those mental health symptoms.
Absolutely. Wow, that was a great overview. Dr. Moore, from your perspective, is collaborative care taking off nationally? Is this a trend that you're seeing? And how can we grow that more in perinatal mental health or in perinatal maternal care, period?
Yeah, I think that there's a lot of challenges there. When we think of collaborative care, it collaborates well when there's a defined group of clinicians who agree to work together. It doesn't work well when said clinicians aren't able to work together. I see Dr. Miller laughing there. And so there's some turf battles, there are some payment issues, there are concerns about what this looks like as we recreate the maternal health system that really takes a team approach that involves every potential contributor to that team, and that centers around that pregnant or postpartum individual and reflects their needs and desires. And right now, I would say we're making progress, but there are certainly a lot of challenges in advancing that and in figuring out how to make that work and to support everybody's role in that model.
Absolutely. It's funny, we're talking about the team a lot and how you need a really effective team. And one of the things about this panel is that we all represent very different sectors and we kind of come at things from a different perspective. And one of the things that the panelists talked about is what is the intersectionality, right? Where do all these different pieces come together? And so I'm going to start with Nakia. And one of the things that employers do is purchase healthcare. And help make decisions around coverage and benefits. And how do you feel that you're either empowered or limited in your ability to really think about perinatal mental health and maternity care in that space and really thinking about those options that you talked about early on?
Sure. So I definitely feel empowered to have these discussions, more so because I've been responsible for care coordination and community health and working, at a plan. So I know things from that perspective as well. But as an employer, we lend our voice and participate in discussions with other organizations like the National Business Group on Health, Northeast Business Group on Health, Health Transformation Alliance, and others, carrier employer work groups, and with our consultants, Willis Towers Watson, Mercer, Aon, you name it. And, based on those discussions and those policy discussions and those options of care discussions, we have a seat at the table, and I certainly do lend my voice in that respective. And when we work specifically with our carriers, we look at their national programs and to see if they meet the needs of our employees based on what the options of care are. And if they do not, then we seek to influence that design. And I can just tell you, participating on this panel and preparing for this has made me go back to the board and say, I feel a work group coming on. What should we be doing more of? So this has been a tremendous help to really just jump starting the 2021 and 2022 conversation.
Wow, that's fantastic. I want to be on that work group, but it sounds excellent. When we were talking with Barry, he introduced a whole new term to me that I hadn't come across yet. In perinatal mental health, we've talked a little bit about value-based payments, where clinicians and payors are working together to make sure that there's health outcomes that are meeting also some payment expectations. But you introduced the concept of value-based contracts. Tell us a little bit about how that, what that term means and how it intersects with the other sectors that are on the panel.
Yeah, absolutely. And I prefer to use the term value-based agreements. Contract sounds adversarial. So That's not the concept here. But I think, we've all heard just how complicated our healthcare system is, how hard it is for patients to navigate that healthcare system, who to go to for what needs. And then we heard from Laura the challenges that insurance companies, who they want to provide the best possible care for their patients. They do not want to stop care. They want the best care. And I've talked to a lot of payers, they want that. But there's challenges in this. So when a company like ours, a biopharmaceutical company, comes in with a new therapy, it's on us to educate the healthcare providers, educate payers on the value of that therapy, and try to remove some of the issues that payers face, things like budget predictability, numbers, and really it's on us to demonstrate that transformative value of those therapies, and then make sure that we're partnering with payers to not limit access. And what typically happens when a new pharmaceutical interventions drug is payers, without that lack of knowledge, with the lack of knowledge, put up, maybe on purpose, maybe not, barriers to that care. So the concept of value-based agreement, very simply, is I want to educate Cigna on the value of our new medicines and agree that if the drug works as advertised, you'll provide access per the label and not limit access. And if it works less well, we'll take risk and make sure that you're paying less if the drug doesn't work as advertised. And that's, as surprising as that sounds, that's fairly new and hadn't been done. In the previous company that I ran, we were able to do that for 3 different drugs proactively, and very happy to report that all of those drugs had virtually 100% medical care across the country, which is not typical. Typically, it's 45 to 60%. So the concept here is by partnering with payers proactively ahead of time, by agreeing to certain terms and conditions where we're going to accept risk, the risk isn't only on them. We provide unfettered access. And in this case, it would be any mom that needs a certain therapy would get that therapy because we're putting our money where our mouth is.
That's great. That's really helpful to understand that. And I'm curious, Dr. Moore, from your perspective, cutting across kind of all the different sectors that are here, where do you see some of the key intersections across, pharmaceuticals and payers and employers and provider groups like Emily's?
Yeah, I think that the common thread through all of this is the pregnant and postpartum individual, and carving out the space and time to listen to their needs and the choices that they want to have, and taking that back and comparing that to the evidence and figuring out how to support that individual and family. And I think also in expanding that, it's this understanding the perspectives of the roles of other stakeholders also. So let's, for instance, take a Medicaid health plan. They may be mandated within their state to engage into a value-based contracting arrangement with perinatal clinicians, but the clinicians are reluctant. And it's really important to find out why. Do the work to co-create that plan that addresses their concerns, including barriers that currently exist, but also they predict will exist. And that the same sort of thread falls through all of these different stakeholders, is listening to each other, but always putting the pregnant and postpartum individual at the center of that understanding and thinking about those perspectives and bringing that in, and not just doing it as an afterthought, I think is really critical.
That's one of the things I think I've heard each of you talk about a lot. And at the risk of turning to a very crass topic then, is this idea of how you think about return on investment. Certainly I think the goal that we all articulated early on is really a healthy dyad, right? A healthy mom, healthy baby, healthy family. And yet it does oftentimes come down to sort of dollars and cents. And Mathematica put out a great report a couple of years ago that really kind of tried to quantify what are we looking at when we don't treat perinatal mood and anxiety disorders. But when you think about the investment that you're making and what that means down the road, how do you look at that? How do you look at that from a provider standpoint, Dr. Miller?
Yeah, I think one of the things that's really hard to quantify when we think about return on investment, obviously health and the longitudinal modeling of health and, you know, the opportunities for, you know, maternal or parental quality of life, infant wellness, like those are front and center unequivocally. But I think there's also other returns on investment that aren't as easily quantifiable, and even tangible things in day-to-day practice, like from a health system standpoint, or you know, I think at Northwestern University where I am, gosh, if I have someone that can help support me in trying to link my patient to a therapist that's accessible and acceptable to that patient, I can scan 3 other patients. You know, there's opportunity costs that I think if we have additional supportive services, we can optimize efficiencies and make sure that we have everyone practicing at the top of their license. I also think it's when we have a system in place that supports a lot of this. And I know that when I screen, right, we know screening is an evidence-based practice when linked to treatment to improve care. And we know that's an evidence-based practice, but so many of my colleagues around the country, they don't screen. And it's not because they're not awesome people that want to care for patients to the best of their ability. They just have no resource. So what's the point of screening if you can't do anything about it? And so I think, again, really thinking about having all of the steps in that care cascade in place is so essential when we think about return on investment, and then thinking about the practical aspects of day-to-day care and what can be done if we have everyone practicing at the top of their license and ready to identify and treat and monitor.
Thank you so much. Nakia, from where you sit, how do you think about, we'll use the term return on investment, although it does seem very impersonal, but how do you think about that in the work that you're doing?
Honestly, we do not use the term return on investment very often, and we don't think of this that way. We focus on initiatives to improve maternal mental health, emotional well-being, resilience, because it's the right thing to do. And it's our value proposition for our employees to focus on what matters to them, and nothing matters to an employee more than their family and their new child and their ability to bring their best self to the situation that they're in. And so just focusing on our culture of health and total well-being is focusing on the family first. So we really do stay away from return on investment and just invest in employees.
I feel like that deserves an applause. That was fantastic. Emily's going to give it, so it's Barry. Dr. Clapper, from your perspective, I mean, what are kind of the cost benefit trade-offs that you all think about, or how do you look at this issue when you're looking to invest more?
Right. I mean, I think there's been several important points made. One is from everyone, you know, as we sit here as different stakeholders in working on this, everyone, how you calculate return on investment is going to be different, right? From Dr. Miller's, you know, how do you have an efficient care team and everyone at the top of your license, versus the employer perspective, maybe also focusing on return to work and other reduced turnover and recruiting and all other things that go that may be calculated, and many employers do calculate into your like perinatal care continuum benefits and programs. From Cigna, I think it's important. And the other thing that really resonated with me that got said was how difficult it is, and what Dr. Miller said about people not screening, because how they don't, they can't refer. It's difficult to refer, both in knowing where to refer and how time consuming it is to refer. And so why bother? And that's actually part of, we did some needs assessment with providers on trying to figure out what we can do to increase screening and referring. And that really resonates with what we found. And that the people who were referring, when they found, were actually telling people to call like the 800 number on the back of their card. So you can imagine how many people, especially if they're feeling, not, being challenged by some of their, what's their condition of anxiety or depression. How often are they going to call and try to talk to someone on the back of their card and then explain what they need? That's a pretty difficult task, and thinking, limited success in how they're going to make that connection. So trying to make it easy for providers to refer and have that connection. So really thinking about perinatal behavioral health as part of a medical neighborhood to the perinatal team, so they can have those workflows already built and be able to share information and know how to make the referral, I think is how we can have the most successful referral. And if people feel confident in referring, they're going to screen more, right? And we're going to have a more timely treatments. And that kind of makes everything work. So if you think about Jim Collins and the flywheel, is what could you do to really make the whole system work for all of us? I think the provider having confidence and being able to refer for treatment successfully is a really key way to make all these different things work.
One of the things that I heard each of you talk about is really efficiency in the system, right? That the more we can plan and think about these issues and really develop that continuum of care, is that you're getting a lot better at doing it, and doing it in a way that is providing easier access to people. Mm-hmm. Dr. Moore, I wanted to give you a chance to chime in real quick on kind of how you think the Medicaid programs across the country really think about their investments in this space, and how maybe they should be thinking about them.
Yeah, what we're starting to hear amongst the various Medicaid stakeholders is not necessarily centered around return on investment. It's really focused on the social investment. And the recent elevation of maternal mortality and morbidity in the nation, and the stark inequities that exist within that, has really elevated maternal health to a space where it's less about the return on the investment and more about, we need to do the right thing. And we need to figure out what that right thing is. And that is a consistent message that I'm hearing from every stakeholder, especially in the Medicaid space, is how do we do this? Because we need to do something. And that is the charge right now.
Wow, that is the hope. I think that Joy was pointing to in her opening session, is that as we center on the right thing, that opens up a whole range of possibilities. We're getting close to our time, so I'm going to do two sort of lightning round questions for everybody. So the first lightning round is what is the thing in your work that you are most excited about? That bright spot that you feel like keeps you motivated and is really moving forward. And we'll start with Dr. Miller.
Yeah, I think the exciting thing to me is that there's so many amazing solutions and so many innovative programs, a lot of which has been talked about today. And so we have opportunities to learn from, the fields of implementation science. How do we get these awesome ideas into practice? And so I think the energy, people's willingness to champion this, to implement what resonates within their specific environment is incredibly energizing. And I can't wait to see a year from now what everybody's doing.
Barry.
Yeah, so I guess three things real quick. One, I love hearing about focusing on doing the right thing. We also don't focus on ROI. We focus on doing what's right for patients. So kind of within that, coming out of the COVID pandemic, I think the world is recognizing that we're in a brain health pandemic. And while that's sad, the good news is that lots of energy and resources going into trying to solve this brain health pandemic, because getting to the other side of that pandemic is what's going to get people back to work, getting our economy back online. And the more recognition that rises there, policy-wise and others, the more help we're all going to get and resources we're all going to get. So that's pretty gratifying. But even more importantly than that, I was recently in an internal meeting where our team was talking about 3 moms that had postpartum depression and were treated successfully and now have plans in place to have another baby and add to their family. And how gratifying is that that after suffering through postpartum depression but recovering, that moms have plans to extend their families as planned. And that's just very gratifying from my perspective.
Wow, I'm taking notes of all the wonderful things. Nikia.
So we have an amazing CHRO, Chief Human Resources Officer, Christy Pambianchi, who is a champion for women and for working women and for working families. And so to have that leadership support and the resources to do what it is that I would like to do in terms of maternity services, and to work with our amazing our carriers, who, if I say it, I dream it. They assemble the team to help us bring that to fruition. So it's a really amazing, set of circumstances to be able to ideate with our carriers to do that. So that is probably just focusing on maternity, period, and listening to all of you, and just the ability to bring these ideas back to the organization and know that we will move the needle because I have the support is really a bright spot.
Oh my gosh, champions are so wonderful and necessary. Thank you for that. Dr. Clapper, what's the bright spot in your perspective from where you sit at Cigna?
Well, I have to say it's inspiring always to hear everything that's being done. And to Dr. Miller's point, how can we more accelerate kind of research to implementation and really get that done? I think that's really important. But I guess the bright spot to me is that we are having so many different modalities that are available. So and programs. So we've made a big push in terms of not only increasing our network, but also being able to see virtual care providers, digital providers, really trying to think through seeing individual versus do you want to sign up for like a 12-week program with U.S.health or something like that. So just the diversity in offerings, I think, is really important. And to other panelists, really thinking about how do we increase equity in maternal outcomes. And I would say that includes, the whole dyad and, families, because we're increasingly concerned in that, and being able to bring data and talk about about disparities and really reduce biases and to increase equity is really important.
I'm glad you brought up the modalities piece. If it's one thing that will be hopefully somewhat beneficial coming out of COVID, is that I think we are seeing more options open up and an ability to access those options. And so it's going to be interesting to see how that continues to evolve. Dr. Moore, what's a bright spot from where you sit?
Mine, feeding off of what you just said, was going to be telehealth. Prior to the pandemic, access and coverage for the Medicaid population to telehealth for behavioral health services was very limited. There have been regulations that have been lifted in order for this population to be able to maximize the use of telehealth to access care that they need. And our preliminary data shows that the Medicaid population actually hates telehealth for physical health, but here's the shining star: they love it for behavioral health. Mm-hmm. And so my response is, I'm really excited about the potential of telehealth beyond the pandemic, looking at how we sustain this access and coverage for the Medicaid population. So this continues to be an option, especially since they love it as an option for behavioral health services.
Thank you for bringing that up. We've had very similar data coming out of Colorado that telehealth, as far as behavioral health goes, is seeing great utilization. I think we only have a minute left. Is that right, Joy, Sarah?
That's right. You can start to wrap up, Rebecca. What a great panel it's been.
Perfect. We had one more question, but maybe I'll ask the panel to put it in the Q&A. Each of them are going to scripted action. What's one thing that we can do after this panel? And I think if we go through them all, we'll go over our time. But I was looking at the numbers and I'm just floored that there were over 300 people listening to this conversation. And I think some of the key themes that came out of it for me is that we have groups across all sorts of sectors. We have industry, we have employers, we have insurers, we have provider groups, and we have payers, and we have researchers that are telling us that this is the moment where we're all centered on it's the right thing to do. And figuring that out versus really looking at what's holding us back. We talked about getting more options, more modalities on the table. We talked about more resources in a postpartum plan and really thinking through that continuum of care and leaning on your champions. And I just want to say thank you to all of you for the work that you're doing and for joining me in this conversation. Thanks, Joy.
Thank you. Great. Thank you, panelists. Thank you, Rebecca. Great conversation. I'm putting some notes soon in the chat that really, these words that resonated with me.